days. And interesting fact is that about a third of them sit around in the spleen, like on call, if you like, I guess. This is a megakaryocyte, so if you've ever looked at a bone marrow examination, these massive cells compared to the rest of the cells, that you can see a neutrophil in the sort of top left-hand corner. These enormous multinucleated cells are these megakaryocytes, and the platelets kind of spew out from that and then are sent in on their merry way into the circulation. And it's all regulated through thrombopoietin. So this is the primary regulator, a bit like erythropoietin for red cells. Thrombopoietin is produced in the liver and kidneys by and large, and it's an inverse sort of relationship. So if the platelets go down, the thrombopoietin goes up, and vice versa. And this has become more relevant in the condition of ITP recently, so just straightforward immune thrombocytopenia, so antibodies against platelets drop the levels. There's newer drugs which mimic the effects of thrombopoietin and just drive platelet production, and that's one of the newer sort of standard treatments for immune thrombocytopenia, as opposed to just straightforward immune suppression. So that's kind of its relevance, really. We don't measure thrombopoietin. If we see a patient with a low platelet count, then we tend to do a blood test, and these are reflex tests, so you wouldn't have to ask the lab for this. If the platelet count's low, there'll be a flag that shows up and says, "Oh, the platelets are low, somebody have a look at this." And so the biomedical scientists in the lab will then look at a blood film and see what's happening from a platelet point of view. You can see the platelets here are labelled A with the arrows, and they're usually fairly small. Sometimes they get a bit bigger. You can see one or two of them are nearly the size of a red cell. That's less common. Sometimes the larger platelets are associated with immune disorders or some congenital thrombocytopenias as well, but there's not a lot you can tell from from microscopy. It's really about the number mainly. Platelets are, to my mind, horribly complicated in terms of what they do. They have an immune, so there's a hemostasis element to it, an immune element to it. They don't just sort of bind to things and form clot. There's a whole process of adhesion and then activation, and then you get the binding. But essentially, if you're looking, I mean, obviously not going to remember all this, but some of the pathways will look familiar from some of the drugs that are used. Things like ADP and arachidonic acid be familiar from the drugs like clopidogrel or aspirin. But essentially, platelets bind to von Willebrand's factor or collagen, and then can be activated via various pathways like ADP and thrombin. And then they bind together via fibrinogen receptors. That's the glycoprotein 2B3A receptors. So pretty sort of multifunctional. There's granules in there as well, so they store things like factor 5, and so there's an extra step in there as well. Most of it gets released, and then is this sort of positive feedback for more platelet binding, and it supports the binding, the formation of clots, basically. Quick look at hemostasis. So just where a platelet's involved in all of this. So you get damage to the endothelium, you get exposure for things like collagen and bound von Willebrand's factor. Those are the sort of things that slow down platelets, and then the coagulation cascade is activated simultaneously, and then they sort of support each other to form initially a platelet plug, and then a sort of fully formed clot which binds platelets, red cells and white cells. So you get this sort of process, and then part of hemostasis obviously is clot dissolution as well. So you want the clot to form quickly, healing to happen, and for it to go away, to have a sort of dynamic process. So if we see patients with low platelets, then this is more in this sort of chronic setting, I suppose, but the long-term sort of setting. But we ask about bleeding, obviously. There's a bit of a difference between primary and secondary type hemostasis disorders in terms of the history that you get. So if you see a sort of primary hemostatic problem like low platelets or von Willebrand's disease, you tend to see more sort of mucosal skin type symptoms, so epistaxis, gum bleeding, easy bruising, menorrhagia. If you have the sort of secondary things like haemophilia, it tends to be the more deep tissue type things as well. So you may get easy bruising, but you tend to get muscle bleeds and joint bleeds, that's a bit different to the low platelets things. So there is a crossover, but classically you get more of these sort of mucosally problems with a platelet type problem. So we ask about epistaxis, gum bleeding, bruising. It's worth remembering that there can be a thrombotic component to these things, and we'll come back to that. But that's obviously what we're seeing with these vaccine-associated thromboses. With platelets, obviously, just need to think about drugs history, and then we also think about things like, bone marrow failure. So it could be a sort of leukemia problem or lymphoma or something like that. Examination-wise, we think about the sort of bruising and purpura and things. Quite a good marker of the sort of bleeding phenotype, if you like. So say someone's got a platelet count of 20 or 30, if you look in the mouth and they've got sort of what we call wet purpura, the sort of blood blists in the mouth, that's often a more worrying sign perhaps than simply easy bruising or sort of skin signs. So that's something that we tend to consider. Don't quite know why that is. And then we think about the reticular endothelial exam. This is probably more hematology specific, but still relevant. And then we have a look into the causes. So we've got a low platelet count. I've done just a few cases actually, just to show the sort of as things get more serious with platelet counts going down. So just to set the scene, if you have a 46-year-old person who has a blood count done, the platelet count's nearly normal, should we be worried? So the blood count's done as abdominal pain. This is just a theoretical example really, but abdominal pain's done, workup, renal liver function, cardiac profile all fine, and the blood film was done as well, that looks all right. So no regular medicines on that one. So in this kind of setting, we think about, do we refer to hematology? Do we repeat it? When do we repeat it? Do we just forget about it? So a few years ago we came up with a sort of referral pathway, and this is mainly for GPs really, but I'll just quickly follow it through. So if you start at the top, you've got an isolated, mildly reduced low platelet count. Most people are not going to be symptomatic unless the platelet count's less than 50. So in this sort of situation, you wouldn't really expect there to be any problems. We've got the red flag at the top, which is if the platelet count's less than or equal to 20, or if there's bleeding, or if there's evidence of a TMA, a microangiopathic hemolysis, then those are the sort of ones you want to get into hospital urgently. But otherwise, you'd look at either referring in or not. And the ones we worry about are sort of 20 to 30 sort of numbers, or if there's other cytopenias alongside it, or if there's a history of thrombosis with it. So those are the kind of red flags, if you like. If not, then we just think about, could it be medication related, alcohol related, liver problems, some viral conditions, and then testing wise, if it's greater than 100, just an annual monitoring test. If it's between 50 and 100, perhaps 6 monthly, and if it's between 30 to 50, it's probably worth referring to the clinic. So this is the sort of setting the scene for the kind of less ill outpatient type management. This is the sort of thing that GPs will be doing, I suppose, if they're finding these tests. And there's some evidence to support this. There was quite a nice long-term study done looking at sort of 10 years of a couple of hundred people who had low platelets, and not very much happens to these people really. They just continue to have a slightly low platelet count, but there's a slightly higher chance of developing immune thrombocytopenia. And because immune disorders go together, there's a slightly higher risk of developing another autoimmune disorder. So, but not something that's overly concerning. Probably the patients who don't have the immune disorders, a decent proportion of those seem to have congenital thrombocytopenias as well, which are not really relevant. So really, once we've sort of established what to do with the very mild ones, we can genuinely be quite reassured with those, as long as there's no other cytopenias and the patients are well. But if you've got a platelet count between 50 and 100, is not usually symptomatic again. That's the sort of patient who, once you've had a look into it and you're happy with the cause, you can usually carry on with most of your antithrombotic therapies, so antiplatelets, warfarin, DOACs, whatever. If it's between 30 and 50, get a little bit more concerned. Obviously depends a bit on the cause, but sometimes, or depends on the cause, but sometimes we do stop anticoagulants and antiplatelet drugs in that setting, probably more commonly than not. And there's some urgency to investigate. And then when it's less than 30, we get a bit more worried about bleeding. So I really want to sort of get on and look into the cause of that, because it's usually more serious. Okay, so sort of second case now. This is a 60-year-old with platelet count 56. So this one has a blood film has been done, as we said it should. And this one shows occasional platelet clumps, and the patient's completely well. So the questions here are, do we just organise a repeat with a film, refer to haematology, repeat the test with a citrate blood bottle, or check haematinics, and so on? And really what we're seeing here is that the hint was in the clumping, really. So there are a few people who have antibodies which cause platelet clumping when exposed to EDTA, which is the anticoagulant that's used in the full blood count bottles. And in that setting, the platelets just clump together and you get a false reading. And if you look at a blood film, you can see them all clustered together. So the counter just doesn't pick them up. And if you send it with a citrate or heparin or another anticoagulant in the bottle, you can actually pick that up and usually get a higher, or even hopefully a normal platelet count in that setting. So this is a sort of pseudo thrombocytopenia. And as I say, that's an antibody mediated thing. It's probably worth mentioning pregnancy, because it's quite common. And it's quite common in pregnancy to get a sort of benign dropping of the platelet count. And if people have a lowish platelet count to start with, then it can drop down to below the normal range, or the lower limit of normal rather. It occurs in about 5% of pregnancies, and it's the commonest cause. But we do need to be careful in pregnancy, because we do see an increased risk of the microangiopathy type problems, so preeclampsia and HELP and TTP and that sort of thing. So we must make sure that we're excluding that. ITP, possibly an increased incidence in pregnancy. And then the other reason why it's important is you do need probably a platelet count of 80 and above for most of the sort of end stage bits of pregnancy to go well. So it's important to keep an eye on that through pregnancy. Okay, so this is a getting more worrying kind of situation. We've got a 25-year-old now with a platelet count 12. So alarm bells are ringing because it's low. We don't know at the moment whether he's going to bleed or clot or what. And this is a guy who's got a headache, feeling unwell. He's dropped his renal function. Clotting's actually normal. He's a bit anemic. And this is the blood film. So just looking at this blood film, there's a few platelets visible, but within this you can see a schistocyte, so a fragmented, broken up red cell. And schistocytes, when they're seen in high numbers, are associated with these thrombotic microangiopathy problems, and the cells are just sort of sheared in the microcirculation. And this was a sort of voting thing that I did for this, but anything where you're worried on this is right, really. The concerns, really, I think, with this are we're more likely to be seeing either HUS or TTP, really. ITP, you tend not to get fragments, and you just need to be worried. So D&E are not correct. So the thrombotic microangiopathies are something I'm interested in, and so these are patients who have low platelets and thrombotic problems, microcirculation type thrombotic problems, and they tend to get damage to brain and kidneys, but also other organs as well. And the one that I'm most interested in is TTP, the thrombocytopenic purpura, which is as a result of this metallic protease called Adams TS13. When that's low, you get TTP. The other sort of differentials really for this would be hemolytic uremic syndrome, and that can be the sort of diarrhea associated, sugar toxin associated, or it can be a sort of congenital complement mediated problem. a much more renal related problem really. Other possibilities, the thrombotic microangiopathies would be DIC, and sometimes we see it in the pregnancy setting as well, so preeclampsia and HELP. This probably doesn't predict too well. It's just a massive list of causes of low platelets really, and I'll go through all them. Just one further thing to consider, I suppose, this is probably more for the haematologists really, but there are a bunch of inherited thrombocytopenias as well. Probably these are more common than we think, but it hasn't been very well defined yet. The more serious ones are the ones that tend to get described first, obviously, because they tend to show up more dramatically, but then the milder ones are starting to be looked into. So I think we are seeing more inherited sort of thrombocytopenia type problems, and I think this area will sort of evolve over the next few years, but I don't think you really need to sort of know too much about them, but just to know that they exist. Okay, so this is going to start off with the opposite sort of problems, like a patient with a high platelet count, but it does eventually lead to something that's relevant, if not very relevant actually. So bear with me on this one. So next case is a 60-year-old with a high platelet count. So this is a genuine case actually, presented with headaches for a couple of months, came to my general heme clinic. They were otherwise well, no bleeding problems, no concerning symptoms other than the headache. So we repeated these and it looked genuine, and there was nothing abnormal going on the blood film other than high platelets. And importantly with this, there was no clear driving factor here, so the CRP was normal and iron stores were normal. So this patient was referred to my clinic and had a JAK2 test. So this is a test for myeloproliferative disorders, and it came back positive. And so myself and the neurologist both requested MRI at the same time, because these disorders are associated with thrombosis, and in fact there was a venous sinus thrombosis present as the cause for the headache. So essential thrombocythemia is one of the myeloproliferative disorders, and associated with JAK2, and this does carry an increased risk of thrombosis. These are just some of the stats really associated with it. So if the platelet count's high, then there's a 24–25% risk of thrombosis, and this patient's already turned up with that. And then that sort of situation, we need to think about antithrombotic therapy and cytoreductive therapy. Typically things like hydroxycarbamide, anagrelide and interferon are used for the cytoreduction element, and then you can look at antiplatelet therapy or anticoagulation depending on whether there's a clot present or not. So in this patient had essential thrombocythemia, so we started heparin with a view to moving to warfarin, and did that. And then the platelet count was being monitored obviously as part of the clinic, and the patient came back and said that actually since starting the heparin, her headache was much worse, and so went to ED, and they knew there was a venous sinus thrombosis. They were on anticoagulation, so discharged with painkillers. But there was a concern here. Now, I'll put these here, but I won't sort of dwell on it for too long because we haven't got that much time. But the concern here is the platelet counts dropped in spite of heparin, and then there's symptoms that are suggesting that the thrombosis is getting worse, which is not what you usually expect with anticoagulation. So if you're looking through these, it's not an allergy to tramadol, it's not an allergy to heparin. The dose of heparin could be inadequate. I don't think the patient's developing acute leukemia, though it's possible. The concern here, though, was actually that they might have developed heparin-induced thrombocytopenia. Now, what's interesting here, just go back a couple of slides, is the platelet count started at 600 and is now 220. And whilst that's still normal, it is a relative drop, and you can get heparin-induced thrombocytopenia without thrombocytopenia. It's just a relative thrombocytopenia. So this is a slightly complex case, but it just illustrates the point really of the level. So we're looking, if you're looking at this, I don't think we need to go through it all too much right now, but there's a a guideline on UHL list diagrams within that, within the UHL guideline. But we're sort of looking at these sorts of the red features get you a high score essentially. So we're trying to work out using this what they call a 4T score to work out whether we need to send a HIT test, and you can exclude a few patients using the HIT score, the 4T score. And then if you use the combination of the 4T score and the HIT test, then you can pick up most heparin-induced thrombocytopenias. So this score is based on the level of thrombocytopenia, the timing of the platelet count, and that's really crucial. Whether there's thrombosis or other problems that are associated with HIT, and whether there's an other cause for thrombocytopenia, which is, you know, stretching it for a T really, but they got away with it somehow. So this is the 4T score. The things we worry about is if there's a 50% platelet fall, so it doesn't have to be low, but typically there's a significant drop from normal of more than half. And usually with HIT, funnily enough, the platelet count doesn't tend to go below 20. That's slightly different to some of the these VIT cases that we've seen recently. Typically the platelets start falling from about day 5 or 10. So that's a very typical feature, and that's because antibodies have to form. We worry if there's new thromboses or skin reactions, get skin necrosis at the injection sites. And we tend to want there to be no other cause evident. That's always difficult for patients who are sick and unwell and having heparin anyway, but that's worth noting in terms of testing. And then just to talk a little bit about HIT quickly, so this is an antibody-mediated drug reaction, and these antibodies form against a complex between platelet factor 4 and heparin. So platelet factor 4 is important in the vaccine-associated thromboses that we're seeing at the minute. So we're seeing this condition is very, very similar to what we're seeing with the vaccine-associated thromboses at the moment. In this case, the antibodies are against heparin and platelet factor 4. For the vaccine, I'm not quite sure what exactly it is, but it's certainly platelet factor 4 mediated in some way. And we're getting this sort of typical 5 to 14 day after the start of the heparin for HIT, and it's the same sort of time frame for the vaccine really. And with HIT, it can be any sort of heparin, but unfractionated heparin is the commonest. This just shows the typical time frame. So we've got the platelet count on the left-hand side there, and the time on the bottom. And you can see here, this is just an example of someone who's been exposed to heparin starting at day 0. The platelet count dips initially. There's a thing called type 1 HIT where you just get an immediate drop, but it's not significant. It tends to bounce back, and then it starts reducing down from about day 5 or 10. And then the hope is that once you stop the heparin, recognise it, then the effects of the antibodies will reduce and the platelet count's allowed to return to normal. It is really important, though, not just to think this is a low platelet count. It's HIT with 2 T's usually, heparin-induced thrombocytopenia and thrombosis, which is what the sort of VIT things come in with, because there's a very high rate of thrombosis, because the platelets are being activated and used up. It's a consumptive activating process, a bit like DIC, where you have patients who get DIC are the very thrombotic patients. Patients who have HIT are very thrombotic, and it's quite surprising. If you've ever seen a really aggressive version of heparin-induced thrombocytopenia, it's quite a frightening condition, really. And the initial rate of thrombosis is felt to be 5 to 10% a day over the first couple of days before you stop heparin and anticoagulate. So it's important that when we're treating, we stop the heparin. Obviously, that's the key thing. But you do need to start an alternative therapeutic anticoagulant as soon as possible, which feels uncomfortable for a lot of patients because the platelet count is in that under 50 kind of range usually. So it's not usually less than 20, but these patients are thrombotic, so we tend to say, well, you know, we just have to bite the bullet and anticoagulate them because they're more likely to clot than bleed, and usually the platelet count recovers quite quickly. So that's the key ring, is get your alternative therapeutic anticoagulant as soon as possible. and we're probably all quite familiar with these drugs now, but usually nobody knows what argatroban is, but we've been using a lot of it recently. Other ones include fondaparinux, and probably the direct oral anticoagulants are suitable too because there's no cross reactivity. Argatroban is the only one that's sort of licensed, I think. Now. And then just a few minutes probably to move on to the thrombotic microangiopathies. These patients occasionally come into hospital. We probably get, for TTP at least, probably get a couple of years, something like that. I'm not sure, probably a few more of the HUSs and a little bit more DIC, I suspect. So not huge numbers though. And these are the thrombotic microangiopathies one we talked about with the schistocytes present. And what we look for with these patients is tends to be a low platelet count alongside evidence of microangiopathic hemolysis. So that's the classic thing. So that's not present in HIT and VIT, but it's present in DIC, HUS, TTP. So you tend to see very high levels of LDH, the low haptoglobin associated with the hemolysis, and then the blood film, low platelets and schistocytes. And then depending on the type of TMA, you either see renal or neurological problems classically, but you can get clots pretty much anywhere in these disorders. So here's the range of them really. So TTP, HUS, AHUS, DIC, malignant hypertension. Not sure that's cause or effect, but obviously it does seem to present in this way occasionally. And then there are some drug associated, transplant associated, those kind of things as well. And rarely we see catastrophic antiphospholipid syndrome presenting in this sort of way as well. This just shows a little bit about the etiology of each of the sort of big ones. So we've got the sugar toxin associated HUS, so you get damaged endothelium, complement activation, platelet activation, and the thrombotic microangiopathy as a result. And then in the middle you've got atypical HUS, so this is a genetic problem with complement activation, and then you get the endothelial damage and platelet activation and the TMA. And then TTP is reduction or defective activity of Adams TS13, and that means you've got these ultra large von Willebrand's factor multimers which are highly active, and they bind the platelets and activate them, and then you get onward damage from there. So they look sort of similar, but they present in subtly different ways. Key things in this sort of setting are sort of getting the blood film really. Usually what happens, I think, in these sort of situations is the low platelet count is found in a sick person and the blood film is done very quickly, and oftentimes the haematology team pick these up in the lab and then go and investigate. But if you think that's not happening, then it's important to involve the haematology team early, I would say, with these. The tests, as I say, are if you see a low platelet count, schistocytes and a high LDH, then this patient's very likely to be heading for a plasma exchange very quickly, unless they've got significantly deranged renal function. But even then, sometimes we just rush on and treat first and then see where we are later. I think this is quite a nice slide, just looking at the differentials, which we've kind of covered already, really. But in terms of decision making, it comes down to the Adams TS13. I'm going to slip on from that one. One thing we do need to consider when we're thinking about these conditions is whether it could be DIC, and you may be familiar with the International Society of Thrombosis and Hemostasis DIC scoring system for overt DIC, and this looks at platelet count for thrombin time or INR, fibrinogen and D dimers, and then that can give you a flavour of whether this is DIC or not. Just quickly moving on to my favourite topic, which is TTP. So this is just a diagram of TTP from the New England Journal. I think the top situation is a normal blood vessel. So we've got sort of blood flowing through left to right, and then platelets, the little blue blobs. The Adams TS13 is the kind of purple Pac-Man like thing, and he's chopping up the von Willebrand's factor these large multimers of thrombogram's factor, which are sort of extruded out through the endothelium through pleural pallade bodies where they're stored, and if they have to be chopped up to become sort of normally active, if you like, and then they perform their function. But at the bottom, you haven't got the little purple Pac-Man things, and the thrombogram's factor multis are just allowed to grow very, very large and highly active, and all the platelets just get sort of stuck on there, and then TTP just goes on from there, really. The key with it really is just to plasma exchange them as soon as possible. It was realised that you could change the mortality from something ridiculous like 90% plus to less than 25%, and we're probably heading towards a situation where mortality is under 10% now, if you can get prompt plasma exchange. So things have moved forward really well. Treatments at the moment also include upfront steroids and rituximab, and we give that to pretty much everybody with TTP now. And then antithrombotic therapy, I haven't put on the newest treatment. So there's a new antibody called caplacizumab, which just prevents that platelets binding to thrombogram's factor. So you get a sort of interruption of the main problem, so you don't get all the aggressive binding of platelets to the ultra large thrombogram's factor multimers, and that seems to reduce some of the thrombotic problems and reduces the need for plasma exchange to a certain extent as well. So there's some new treatments coming along all the time. And why is that relevant? Well, it's at the moment, I think we're just in the process of there being a central sort of commissioning model for this. So it's sort of highly specialised commissioning. There's probably going to be about 8 or 10 centres across England. We are highly likely to be one of those centres in combination with Nottingham, assuming things go to plan. And what we're hoping is we won't see too much difference in activity from what we're seeing at the moment, but we'll be part of the sort of expert group in managing TTP and thrombotic microangiopathies. And that should happen this year. And that brings me to the end of my talk. So if there's any questions.
Anybody have any questions?
If we became a sensor, how many patients would we have?
Did you hear that?
I'm sorry, I didn't hear that actually, sorry.
If we were to become a centre, do you know how many patients we'd end up seeing? Because presumably quite a lot of them would come through us.
We'd probably see about 2 a year.
Oh, okay. We can probably cope with that.
Yeah, we're not. The good thing is we're not expecting. One of the thoughts was that that either Nottingham or Leicester would end up being one of the centres, but we've come back to NHSE and said, can we just do it together? Which means there's no change in the frequency of patients that we're already seeing, so it's pretty much what we're already doing.
Fair enough. Yeah, we do. Yeah, it's not common, but we see them occasionally, but not huge numbers.
There may be some further discussions to be had with the ITU about this, I guess.
Yeah, that might be.
I know it's been an ongoing sort of conversation for years now. I don't think no one believes me anymore, but it is actually happening.
Okay, fair enough. Yeah, just let us know. Guys at Glenfield, got a question?
Yeah, thanks, Kaz. I've got a question. Thanks, Richard. That's a really interesting presentation. I've got a question for you. We get a bit jumpy when we see high platelets. For example, in a patient who's been septic and then gets, the platelets drop and then they usually overshoot. Should we be treating them with antiplatelet agents? And if so, at what level? At 1,000? At 800? I think we generally start a bit of aspirin at 1,000, but I don't know if that's evidence-based or sensible.
It's difficult actually because when platelets go very high, you don't quite know what's going to happen next. Generally, for the reactive ones, if they're in hospital or whatever, you tend to just carry on with standard thromboprophylaxis with heparin, and you wouldn't need an antiplatelet drug for any reason particularly. So I wouldn't necessarily recommend an antiplatelet drug in that sort of setting. What can happen sometimes for very high platelet counts once you're getting over sort of 1500, 2000, you can get a condition called acquired von Willebrand's disease, where the sort of condition tips more towards bleeding, and the reason for that is that you get sort of an adsorption of the von Willebrand's factor, so you sort of go too far the other way. But yeah, when if they're sort of somewhere between 500 and 1500, and it's just a reactive thing that settles, I think probably standard thromboprophylaxis would be fine.
Brilliant, thank you.
We have a question here, go on.
Can we use intravenous immunoglobulins for HIT as it is immune mediated?
Yeah, we don't tend to actually. The main reason, I suppose, is that it tends to just get better once you stop heparin. So as long as you stop heparin and anticoagulate, then they do tend to improve. So I can't remember the last. We don't see very many patients with HIT, but I don't think I've ever immune suppressed someone with HIT. Actually, I think we just stop the heparin. But I think this thing's a bit different because obviously the antigen may hang around a bit more, or the antibody may be something that's not as sort of drug dependent in a sense. I don't quite know really with these ones. So that's where the IVIGs sort of come in, and it seems to have a really good immediate effect. So because you can't stop the vaccine, it's already in there. That's the problem, I think, with this sort of thing. Yeah, although having said that, for heparin-induced thrombocytopenia it might work. It's just that we don't tend to do it actually.
Yeah. Kaz?
It's Rajni, just following on from Kaz's question, in COVID patients who've been, when we've audited some of them after discharge, after the first wave, and some of them have been quite high platelets, from 800 to 1,000 or so. And I know definitely one of them went on to have a PE while, post ICU discharge, but while still in hospital. So he was treated with anticoagulation and things like that. So would you say that we would need to have some sort of an anticoagulation post-hospital discharge for the COVID patients? Probably,
yeah. I don't think we never really bottomed out how long you need anticoagulation for. And the journey, I think obviously fairly on with COVID, it was recognised that there was a thrombotic component, but then how to stop and treat was a more difficult thing. It seemed to emerge as the sort of studies went on that probably you need higher doses of anticoagulation earlier in treatment. That seems to be the most beneficial. But if you start, the studies were all done, I think, in sort of treating more aggressively later on, and that led to that unusual sort of finding where it seemed that the outcomes were worse if you used therapeutic anticoagulation in the ICU sort of setting, as opposed to just prophylaxis. I suspect that probably reflects the fact that these patients needed anticoagulation earlier. So the current sort of treatment would be patient comes in with COVID, if possible, give therapeutic anticoagulation. Argument to sort of step down to prophylaxis or intermediate dose if they end up on ITU or with high level organ support, and then probably just carry that on to discharge and for 7 to 28 days post discharge as well. But yeah, I guess we're all just sort of, yeah, it kind of, I think it makes sense, but we don't know for definite.
I just feel like we're making it up a bit as we go along.
Yeah. We just pulled the evidence together in time for the pandemic to sort of settle down again. But whether it'll pick up, if it does pick up, we should be a bit more ready.
Martin, did you have a question?
Yeah, I mean, it's a question you might not be an answer to yet. So we had a patient who needed a laparotomy with ischemic bowel after a vaccine-related clot. She came in with platelets of about 25. Clotting wasn't vastly deranged on the numbers. Fortunately, she didn't bleed. If they do bleed, apart from giving immunoglobulin, is there anything different we should be doing to try and kind of resuscitate them? Yeah,
if they bleed, I suppose people are giving platelets for these cases, but you don't want to. So I suppose that's the situation. The other option, perhaps in that setting, if someone's stable enough, might be to plasma exchange. We've not done that for anybody here yet, but some centres have. So really, people are just pushing immunoglobulin, trying to avoid platelets. For high-risk patients who aren't actively bleeding, we've been using argatroban. For more stable patients, we've been using the sort of more typical non-heparin anticoagulants, and then reserving plasma exchange for the really sort of sick ones. So that, I suppose that's probably the options there. But yeah, it's funnily enough, we haven't seen much bleeding apart from sort of secondary bleeding from the congestion type issues. I think this patient had some, obviously bleeding in the bowel, but it was venous congestion sort of related by the sounds of it, and some of the venous sinus thromboses can bleed from that sort of congestion problem.
Yeah, it's difficult to plasma exchange when they're in theatre, but bleeding. But
yeah, exactly. Yeah, that's the. I don't
really. This might be a bit concerned about, but yeah.
Well, I suppose, and just another quick question. I mean, I think I may know the answer to this, but it's very difficult to. Well, people tend to reach for tranexamic acid when people are bleeding catastrophically, and my gut feeling is that might be a very bad idea, but I just don't know.
Yeah, I know there's loads of evidence that tranexamic acid doesn't cause thrombosis problems, but I'd be very nervous in this situation as well, actually. So I'd avoid it.
Yeah, fair enough.
and just get platelets, I think. Yeah.
All right. Shall we move on? I think.
So we've been hearing about this vaccine-induced thrombocytopenia, which is a new terminology that has just been introduced and recommended by various people. So there's been a lot of mystery, and we didn't know much about it. And there were 2 case series that were published in the New England Journal of Medicine last week. I stupidly shared one of them onto a WhatsApp group and got asked to present this. It's not an easy journal to read. So this is the German/Austrian one. And this is the one that I'm going to be talking about. But in the same on the same date, there was also a Norwegian one with 5 patients in it, and both are really good articles, and I'd recommend you to read both of them. And so this particular one collects patients in Germany and Austria, and I don't know whether they've collected everybody in Germany and Austria, or whether they've just collected a small selection of them. But essentially, they reported 11 patients plus an additional 20 blood test referrals from other hospitals. So they had a total of 28 patients in this paper. It described an index patient with who was 49 years old, who was a healthcare worker. She presented with fever, nausea, and epigastric pain. She had some constitutional symptoms when she had the AstraZeneca vaccine for the first few days, but that didn't resolve. And on the 5th day, she started getting more fever, nausea, epigastric pain. And on day 10, she was admitted with these symptoms. And on the CT scan, it showed small bilateral PEs and a portal vein thrombosis. So she was, and also a platelet count of 18 to start with. So she was given a small dose of enoxaparin, 40 milligrams, and she was given a platelet transfusion as well, and was transferred to a tertiary center. And on arrival at the tertiary center, she was in with what was described as good condition. I assume she was not intubated and was relatively well, feeling a bit nauseous. But on day 11, she had worsening symptoms, was admitted to ICU. And on a repeat CT has shown progression of thrombus, and now includes the arterial system in the iliacs. And then she had some platelets as well, and given some antibiotics, and she was given a heparin infusion, which was a very low dose heparin infusion. And then she developed a GI bleed, and then she died. So that was really quite scary. And if my wife looks at this, she would absolutely not have the vaccine anymore. This was what the lab characteristics of this particular patient. So it started with a platelet count of 18, and it seems like it incremented to 37 with a bit of platelets, and then it dropped again. And other abnormalities are, firstly, the D dimer was really high, 35 in their units. I think I calculated this to be 35,000 in the units that we normally use. And also the gamma GT is a bit raised and the CRP is a bit raised, but otherwise other bloods were pretty unremarkable. So this particular paper collected a bunch of patients with some clinical details, and we have some details here. So all of them had the AstraZeneca vaccine because the Johnson & Johnson vaccines are still not available in Europe anyway. And the platelet count varied from 8 to 107. And out of all of them, only 4 survived out of 11 patients. The thrombi seems to be in very atypical places that we don't often see in our normal patients. So cerebral venous thrombosis in some of them. Splanchnic vein thrombosis seems to be featuring in some of the patients. PE, surprisingly, only 3 patients, but also in the aortic, in the arterial system as well, the aortoiliac, microvascular, I don't know what that actually means. And 1 patient didn't have any evidence of thrombus, but just had cerebral hemorrhage and died on admission. And seems like the only common thing they have is a very high D-dimer. And also many of them have low fibrinogen count. And this is really puzzling and quite worrying. And I'll tell you more about this. So they've done a hit screen on all of them. And the ELISA screen was positive in all of them. And they've done a special PF4 dependent platelet activation assay, which was positive in all of them, which I'll tell you about. So this paper described how they tested for it. And this is what they wrote. This is how they wrote it. And I don't think they wrote it really well. And I had really difficulty trying to read it. I read it twice and understood 20% of it. And I had to do a deep dive on it to try and understand what they were trying to say. So I spent hours looking at this, and I'm going to save you a lot of time and present to you in 5 minutes, okay? So for hit screen, so we need to know about hit screen before we know about how we test for this, because the testing is essentially the same. So like what Dr. Gooding has described, step 1 from hit screen is to do a 4T score. And this is really important because we want a pre-test probability for this. Because in step 2, we do antibody testing. And in this particular paper, we use ELISA testing normally with the ELISA for heparin PF4 antibodies. But this paper also uses ELISA for PF4 specific antibodies only. But most of our hit screens use the heparin PF4 antibodies. And what this test tells us is whether there is any antibody or not towards the heparin PF4 complex. And the result is presented as optical density. So the higher the optical density, the more significant the result is. I'm sure you remember the physiology from medical school, where if we give someone heparin, some of the heparin gets bound to PF4. And what it normally does, it helps the heparin get absorbed and metabolized by the reticular endothelial system. In some patients, I believe Dr. Gooding can correct me on this, I think between 5 to 10% of patients receiving heparin, they will make heparin PF4 antibodies, but this is of no significance. Therefore, this antibody testing is very sensitive, but it's not specific enough to diagnose heparin-induced thrombocytopenia. That's why the 4T score is so important, because if there is low pre-test probability, then we should not do antibody testing. But if there is intermediate or high pre-test probability, then ELISA is really helpful, because if the ELISA is negative, then it's unlikely that you have hit. So like I said, in this paper, they have used ELISA for both heparin PF4 antibodies and also PF4 specific antibodies to diagnose the condition. And then what they did next was, and in the normal hit screen, if we have positive ELISA, the hematologist would normally phone us and say, hey, we've got a positive hit antibody. This patient may have HIT. Can you tell me the details? And we're going to send this off for confirmatory testing. And this is what they meant by this. What they normally do next is send this to a tertiary center for functional testing. And this particular paper talks about heparin-induced platelet aggregation. So what normally happens is you take platelets from healthy donors. So normally from what we normally donate blood, and they get platelet from these patients who have not received heparin. And then they take the patient's serum, which presumably contains the antibody to these platelets. So they add the patient's serum to normal platelets, and then under normal circumstances, they add a bit of heparin into it. And if the platelet aggregates, then we confirm the presence of these antibodies against the platelet heparin complex. And this is how they do functional testing. Okay, so we're going to come back to this paper now. So what they did was they did an ELISA testing. They used 2 ELISAs, so the PF4 heparin ELISA and a PF4 only ELISA, and all of the patients were positive for them. So this shows that we can use a normal HIT screen to identify patients with vaccine-induced thrombotic thrombocytopenia. So you can see in the middle, it says PF4-heparin with 100 units per mil of unfractionated heparin. So that's a bit confusing, and it doesn't mean that heparin stops this from happening. If they use high dose heparin in the ELISA tests and if this suppresses the ELISA test, it further confirms heparin-induced thrombocytopenia. So it's a bit confusing. So you just ignore it. Okay, so ignore the heparin bit. And then this paper did platelet activation assays, and they did a lot of stuff with it. They did some experiments with it. So you could see. So first they used 4 patients' serum to do platelet activation assays, and they got some results, and they were really encouraged by it. So they did the rest. They did the same with the rest of the 24 patients, the 24 samples that they had. So normally in HIT, you add a bit of heparin into it. So in this case, low molecular weight heparin, you would see platelet aggregation. But in these vaccine-induced thrombotic thrombocytopenia patients, the platelet activation assay seems to be quite mixed, so we can't really use that to diagnose patients with VITT. But they added some recombinant PF4. So if you look at the bottom one, I don't know if you can see my mouse, they added some recombinant PF4, which pushes the reaction time to very short reaction time, which is a positive test for platelet aggregation. And also, they added some IVIG to some of the patients, and that suppressed platelet activation in these patients. So according to these in vitro studies, it seems that IVIG can work for these patients to suppress platelet activation. So this is a treatment guideline that they produce for this particular paper. And what they said was that if someone's received the AstraZeneca vaccine with no previous heparin exposure, and they present with thrombocytopenia, thrombosis between 5 to 20 days after vaccination, you do a screening test with your ELISA testing, and you also look for the IC with your INR D-diamond fibrinogen. If the ELISA is positive, then you refer for functional testing, which, to be honest, personally, I don't think this is really helpful or required. You make a diagnosis based on that, and you treat the patient. And what they've recommended is you treat with IVIG, and you avoid platelet transfusion. Now, this is a case series, and it's not really a randomized controlled trial. So it's really helpful and fascinating. But again, it is not intended to prove causality of the vaccine, although it's fairly convincing now, and is not intended to show effective treatment options. So in my conclusion, according to this paper, vaccine-induced thrombotic thrombocytopenia behaves like HIT, but it seems to cause more clots, it can cause more bleeding, it can cause DIC, and it seems to be the hematologist's ultimate nightmare. You can diagnose it using a standard hit screen. And the treatment that they've recommended is by using IVIG, consider non-heparin anticoagulation, and avoiding platelet transfusion. Now, in the last week, a few more case series and case studies have come out, and there's another, I mentioned a Norwegian study with 5 patients in it. 3 died and 2 survived. They did use heparin in some of the patients, and 4 of them received IVIG and 2 of them died anyway. So I don't know whether IVIG works or not without the presence. Well, we probably will never know. And in other case studies that I've read, it seems like some of them have used heparin and the patient survived anyway. So perhaps we could still use heparin for these patients, but there's a lot we don't know about it. And I'm sure Dr. Gooding has some inside information about this and whether we can actually use heparin or not. But this particular paper recommends the use of non-heparin anticoagulation. And in our case, we'll probably end up using algatraran anyway. And that's it. That's all I have.
Thanks, Frank. Have you got anything to add, Rick?
Yeah, no, it's just we've had. I know these case series have come out now, but we've had 7 cases now in the last 2 or 3 weeks, something like that. One in the last one a day for the last 3 days. So it's clearly pretty common. I don't know quite why it's so common, and whether it's just reflecting the fact that we're now vaccinating younger people, and it seems to have a sort of predilection for the younger people. So most of the cases are being seen in those sort of 40 to 60 kind of year olds group. So yeah, I think we're going to have to get used to this quite quickly. But exactly, I think it's exactly what you said, in terms of the treatment. And like you said, we're not for HIT, although they did all the tests there, we very rarely go and do the serotonin sort of confirmatory bits. It's usually just the 40s and the confirmatory test, which is either an ELISA or the one we use is called an AccuStar. It's a chemiluminescence one, but it's a bit like a sort of liquid phased ELISA type thing. But not all that our HIT test in Leicester is not sensitive to VIT for some reason. So we're sending them away at the moment to London or Bristol for the ELISA tests. But it's once you see it, it's not, it's just low platelets, crazy high D dimer, usually a headache and whatever other thrombus they've got, and it's pretty typical. And even if we're not seeing clots, we're treating them just like we would HIT, really. The one thing we're just looking at the moment actually is had a few discussions. I don't know if Nottingham are doing this, but we're sort of starting conversations with radiology about how we should go about imaging all of their blood vessels if we can in one go, sort of thing. So we're looking at a sort of extended CT angiography test so that we can have a look at everything, because we've had patients where there's been clots. The worst one I think I've seen was aortic, portal vein, venous sinus, arterial stroke, brachial embolism, just clot everywhere basically. But I suspect if we scanned people, we would find clots in a lot more places, and that may help define things in terms of what we do next, because the big question after they survive the first episode is what happens next, and we don't know what the natural history of this is going to be. Will they relapse a couple of weeks later when the IVIG wears off? How long should we anticoagulate for? Those kind of things. So all that's going to follow soon, I suppose.
The ones that we've had that have died have both had brain clot, haven't they? And they've ended up coning. They're both young, so they don't have a huge amount of space in their head. So there's one arterial and one venous clot, wasn't it? Yeah. The impression with these is, it's strange actually. I don't know whether they're just getting a sort of sluggish flow phenomenon or whether it is just clot related that we're not quite picking up somehow. But Nottingham are very kindly accepting those sort of higher risk ones to refer on early, just in case they need that sort of supportive craniotomy, really. Sam says, are all cases still after a single dose, or is it after the second one at all?
Yeah, they all seem to be first dose so far.
Yeah.
So the idea is really to spend most of the time discussing a novel paper, but just each week to just recap a classic paper that everyone should hopefully be familiar with and hopefully have an opinion on. And along the theme of bleeding and clotting, I thought this week we'd do the woman trial, which is quite a newish classic paper, and that was published in 2017 in the Lancet. And it's been a while since I've done any obstetric anaesthetics, but I always do like to ask obstetric anaesthetists whether or not they give tranexamic acid after this trial came out. So the premise being is that postpartum hemorrhage is a massive cause of maternal mortality worldwide, accounting for about 100,000 deaths a year. As you can imagine, most of those occur in low and middle income countries. And whilst we can do all the things to optimize clotting, really the idea is that tranexamic acid is cheap, simple, readily available, that if we can inhibit fibrinolysis, then perhaps we can save some of these women's lives. So it ticked all the boxes with regards to design, in that it was not even multi-centre, but it was multinational. In fact, it was done across 21 countries, 193 hospitals. It recruited over 20,000 patients, so an enormous trial with really good power. It was randomised, it was double-blinded. So you just picked up a pack, you got some clear coloured solution, you didn't know whether you're giving normal saline or tranexamic acid. And it was so placebo controlled by Pfizer. So as I said, it was sodium chloride. You either gave a gram of tranexamic acid over 10 minutes, and then you had the option of giving another dose if you wanted to, but it had to be at least more than 30 minutes after the first dose, and it had to be within the first 24 hours. The other things is that I think is important in a study like this is that it's pragmatic. So it was a clinical diagnosis, so the clinician at the bedside made a decision that this is postpartum hemorrhage, and the rough criteria for inclusion for that is after a vaginal delivery, estimated blood loss of more than half a litre versus more than a litre if it was after a caesarean section. And it was all women who obviously had babies who were 16 years of age or more, and it was approved by ethics. So their outcome measures that they chose, so first of all their primary outcome was a composite, and clinical trialists who are purists will say they don't like composite outcomes because it's sort of a bit of a mishmash of a few things, trying to hope that small gains here and there will come up to something meaningful. But it is only the composite of two outcomes, and that's death from all causes. And again, you think, well, how's tranexamic going to help you reduce your death from anything other than bleeding? But if you think about the consequences of massive transfusions, you might get TRALI, and if even though the studies have shown that you don't increase your venous thromboembolic events with giving tranexamic acid, dying of a DVT or a PE or something may be significant or relevant, or the need for a hysterectomy. So it was a combined of those two things, and actually partway through the study the primary endpoint changed. They increased their sample size, which initially they planned at 15,000 and made it 20,000. And the reason they did that was because quite often the decision to randomise, the decision to include the patient in the trial came at the same time as the decision to do a hysterectomy. So it's not fair. But in reality, the reality is, isn't it, is you don't just do one thing and see what the outcome is. You're doing lots of things. So you're trying to optimise you're pushing in your blood products, you're trying to do some surgical control, you may be starting some uterotonics, you're doing multiple things at once. You don't ever do one thing in isolation. So they changed the primary outcome to look at bleeding specific mortality. So that was during the study. Secondary outcomes was sort of the subgroups of the etiologies of death, venous thromboembolic complications, surgical complications, and other things. 42 days, again, when I first saw that, I thought, you know, what, tranexamic acid's got a half-life of 2 hours. How on earth is it going to impact on your outcome? But again, if you think about those things like TRALI, plus or minus DVT, PE, they're going to have effects sort of that aren't necessarily immediate. So the results showed that there was absolutely no difference in the rates of hysterectomy, and that there was no significant differences in all-cause mortality. But there was a significant reduction in the tranexamic group in mortality attributed to bleeding. And I think on face value, you know, this is a brilliant study. It's going to save loads of lives worldwide. But if you try to think about the external validity of that trial, to our population, because this trial was done across lots of countries, lots of sub-Saharan Africa. And you think in a country where we have access to lots of blood products and we have readily access to theatres and surgical techniques and things, is it really going to save our life? 99% of those women who are dying from bleeding are not dying in the UK. The thing that I think is interesting, therefore, when you look into the study a little bit more closely, is that actually the blood transfusion rate between the two groups did not change at all. And the median amount of blood given was no difference between the two groups. So tranexamic acid, if it saves you alive from bleeding, then what I suspect, and even in the supplemental material, it's not obvious, it's not clear, they haven't broken it down by income countries, is that if you're in a centre where you have limited access to blood products and you have maybe limited access to surgical techniques, it will potentially could save your life. But here in Leicester, I'm not sure that I think it would necessarily. But on face value, the trial says it saves lives, and of course it's a fantastic trial for the world and sort of internationally. I just briefly touching on a couple of other studies. So the CRASH 2 trial is the trial that looked at hemorrhage in relation to trauma and the use of tranexamic in that context, which is now standard. That was their findings, that the importance of giving it early, tranexamic acid, if you're going to give it, giving it early is incredibly important. It was echoed in the women's study. So one thing we can take from both of those trials is that if you are going to give tranexamic acid, give it early. And it's about 10 years ago since I did ATLS, but I remember somebody telling me your first clot is your best clot. And I guess that sort of premise, at least, is echoed in the idea that, you know, if you're going to protect your first clot rather than trying to, when you're struggling later on, giving extra blood products, trying to recreate clots that have broken down. And finally, again on the tranexamic theme, if you sort of trying to encourage you to not just read the bottom lines of the summaries of the abstracts of studies, but try to think about how internally or externally valid it is to your population. So the CRASH 3 trial looked at use of tranexamic acid for traumatic brain injury and showed no mortality benefit. However, if you look in detail again at the results of this, and you excluded people with fixed dilated pupils and who were GCS of 3, so severe traumatic brain injury, which is arguably, you know, I don't think tranexamic, I use it a lot, I quite like it, but I don't think it's magic. It's not going to reverse your pathology. All it's going to do at best is stop your hematoma growing or getting bigger. If you exclude those patients, it actually did show a mortality benefit. So on face value, that was a negative trial. And then you think, well, you know, that's the most hypothesis generating. So we shouldn't use tranexamic acid until someone's done a study. But then you've got to think about the pragmatism of it as well, is that if you're going to have such narrow inclusion criteria that you've got to have a hematoma more than such and such on a CT, then realistically, by the time your patient's been to CT, it's been reported, all of those things have happened, you're going to be outside of the 3-hour window. So there has to be a bit of clinical context and interpretation to these things. So in summary, if you're going to give it, I don't mind people giving it or not giving it in Leicester, but do give it early. Give it the way it should be given. So CRASH 2 and CRASH 3 gave 1 gram over 10 minutes and then 1 gram over 8 hours as an infusion. The half-life of tranexamic is 2 hours. I often see it get given as 1 gram TDS, and pharmacologically, I don't think that quite makes sense. So yeah, maybe give it the way it should be given, and then sort of just think about how your population group fit into the studies that are being shown. So for the woman study, I think it's perfectly reasonable not to give tranexamic. And also, I don't know, maybe it was just when I did obstetrics, I felt like everyone had a bit of a PPH. Maybe a massive PPH, I'd give tranexamic acid, but I think at 500 mils or 1 litre, I'm not bothered either way. But I'm interested to know what other people think or what they do.
Thanks, Eden. When you ask the obstetric anaesthetist whether they give it, what do they say?
Well, I haven't asked anyone in England yet, but in Sydney they tend to give it. and they base that on the woman study. But I still don't think that the mortality benefit is those seen that are in the English and first world country patients.
I was just trying to remember while you were talking. I'm pretty sure any PPH that we get on the unit, so they generally have had a reasonably sized PPH and blood transfusion. They've had tranexamic, although they don't usually get the 8-hour infusion. They just get it a stat dose in theatre usually, I think, unless anybody that works here can contradict me.
But I think that's more than a PPH. That's probably like to come to ICU afterwards. You've probably maybe got a Bakary balloon in, or there's been a massive PPH potentially.
Sam, did you have a question?
No, just a quick comment about the methodology. I think it's a bit tricky in this condition because we know quite well tranexamic works better as a prophylaxis rather than treatment. Once you reach that stage of fibrinolysis, it's a bit too late to give it. And looking at the enrolling of patients, a lot of them, I think, happened quite late. Now, where is the balance? Are you going to give it to 20 or 50 patients prophylactically to save one? I don't know. I think that's the challenge. Maybe that's why they couldn't find any benefit really in this case group.
Yeah, maybe. Anybody got any other questions or comments? Rich, anything to add?
Yes, we have used a lot of tranexamic acids in various situations, but actually recently it doesn't seem to have any benefit from a GI bleed point of view. So yeah, the real benefit does seem to be when it's given early, doesn't it?
Yeah, and the trauma, we don't get a huge amount of trauma anymore, but the ones that we do get tend to be really sick, and the paramedics, it has often been given pre-hospital. If not, it's definitely given in ED, and then the anaesthetist will usually run the 8-hour infusion as kind of standard practice now, which is good.
It's interesting, there's not a lot of evidence for a lot of the things that we do in the setting of bleeding. I don't think it's sort of something to do. You know, the DOACs are a good example. You know, there's, you know, if you've got someone who's bleeding with a direct oral anticoagulant, there's no reversal for most of them. So we give PCC, but there's not a lot of very good evidence that there's a definite clinical benefit with that. It's just sort of something to do while the drug wears off and you're supporting the rest of the things. So I don't know. And that's whether that'll change with the new reversal agents that are coming out. They're so expensive that I'm not sure they're going to be taken up either, because the evidence even for those isn't that great. But at least tranexamic acid is sort of cheap and easy to use.
Yeah, it's in the cupboard. We give it for all of the hips and replacements and stuff, so it's just easy to grab.
Yeah.
If it makes you feel any better, there's not a huge amount of evidence for most of what we do in ITU either. So,
but it seems to be working. You guys are gonna have to say he's done a very good job.
Maybe. Does anybody else have any questions or comments? Put it in the chat or not. If not, I'm just going to share this, which is a QR code for feedback. If you can take a picture and fill it in, then you'll automatically get a certificate of attendance, and the comments would be great, and feedback to those that have presented for appraisals and ARTPs and stuff. I'll post it in the chat as well if people are watching it on their phone, so they can do it afterwards. Otherwise, thank you very much everybody for joining in. Thank you, Rich, very much for being involved and staying in for the General Club. It was very much appreciated. Your input's quite valuable at the minute, particularly. I'll leave it there, I think.